This is Midweek Politics with Dave Pakman.
Craig Melin is with us, President and CEO of Cooley, Dickinson Hospital in Northampton, Massachusetts. Thanks for coming in today.
Good to be here. Thanks.
You have been employed by a number of different hospitals, some for-profit, and currently Cooley Dickinson is non-profit. Is that correct?
No, actually, I've only worked for not-for-profit hospitals.
So your entire career, you've been in the non-profit hospital sector?
With the exception of a 2-year stint where I was a consultant to hospitals.
So in your experience, is it fair to say your experience as a hospital administrator in the nonprofit side is somewhat different, very different than that of the for-profit side? Or would you say that overall it's similar on a day-to-day basis?
Well, I haven't experienced working in a for-profit organization. One major difference is what it is that we need to do for access to capital. Not-for-profit hospitals, we can only spend what it is that we bring in as a surplus or perhaps against depreciation. A for-profit could sell stock and have a different kind of access to capital. So for those of us in the not-for-profit field, if the economics aren't working, we're probably not working either. Given the fact that in Massachusetts, Massachusetts does contain some of the framework of the health reform bill that was passed more broadly nationally in the last couple of months, what would you say is the biggest concern in what's been passed nationally? That either something that's in there that you don't like or something that's not there that maybe should be? Personal view, I'm much more interested in making large jumps to where we want to be rather than moving incrementally. I think as a nation, most people were looking at what changes they were willing to make compared to what it is they already know well. So if we didn't have to deal with the politics, I would have preferred a change that moved us more directly to where I think healthcare needs to be, which is a population-based approach. I don't think that was politically viable. And so the adjustments that occurred were those that people could tolerate.
As a hospital administrator, would you favor a single-payer plan? Single-payer system, I guess, is a better way of saying it.
My answer used to be no, because I had fears about what would happen if the single payer were someone who, or some organization like, say, the government, that would be so focused on what revenue they had coming in that might affect the care delivery system. The more I've watched the current payment system play out, the more I believe in at least a single payment system. The difference for me between single payer and single payment is if we were all paid the same regardless of who the insurer is, then we lose some of the confusion and the multiplication of administrative work that we have to do. And the insurers would still have a role. Single payer gets scary for insurers because they don't hear themselves in that plan. Single payment, in my eyes, would accomplish what single payer seeks to do, which is full access for everyone and get rid of all the complications and a staff in our place of 150 people in finance just to take care of all the different payers. If they all paid the same way, we could get rid of a lot of the duplication.
So what you're, correct me if I'm wrong, but what you're saying is that the way that the system works now, you essentially need almost like if when you went into a store, if you wanted to use Visa, there was one mechanism for accepting Visa. And if you wanted to use MasterCard, there was a completely different mechanism. You needed somebody else to run that machine, and you needed to buy extra equipment to take that payment. That's essentially between insurers, that's what exists?
And the rates are all different. So using your analogy for a moment, essentially, if there was just one credit card system and everybody was using it, whether it was American Express, Visa, or MasterCard, or whether it's Blue Cross or Harvard or Tufts or Aetna or Cigna, if they were all doing it the same way and the payments were all the same, we would then have one set of incentives that made sense rather than each plan thinking they have the best of incentives. And when you put it all together, it doesn't make any sense.
So to clear up, fee-for-service essentially means the more things for each patient that a hospital does, visits, checking on something again, a test, 2 tests, procedures, they get paid more, separate from how well that patient is doing. Is that correct?
It is correct, except that depending upon your values, like at Cooley Dickinson, we have a major investment in prevention and keeping people out of the hospital. So instead of more procedures per patient, it's attracting more patients to the hospital, but that means attracting patients from other hospitals. Meanwhile, every other hospital also has an incentive to attract patients from their hospitals. And you see some hospitals, a lot of hospitals, doing an intensive amount of advertising, so much so, but it can have no impact if everybody's doing it. The state of Vermont is now looking at eliminating hospital advertising altogether, because essentially it doesn't do anything by the time people are done.
Midweek Politics is brought to you in part by Jackson & Connor, classically modern men's apparel in Northampton, Massachusetts on the second floor of Thorne's Marketplace, and by DIF Design, specializing in custom business websites at difdesign.com. To find out more about underwriting Midweek Politics, visit midweekpolitics.com.